I'm Ezequiel Baran. I'm from Argentina. I'm an internal medicine physician at the Hospital Rossi in La Plata city, which is near Buenos Aires. It's the capital of the state. We are from an adult cystic fibrosis center. We assist about 88 adult patients that came from transitions from another hospitals from La Plata, Buenos Aires, Mar del Plata, which is a city near about 400 kilometers from La Plata, and also from Cordoba, from Mendoza, from Santiago del Estero. There are different states. There are some centers in Argentina, all centers. There are about 8 all centers in Argentina, but we are the oldest one. There is a law in Argentina, CF law, it's called like that. And until 2019, I think it started. And it's by law, everyone who is born must take the tear test. And it's working very good in cities or populated cities, but no as well as in the middle of the country. When the tear test is positive, they have to make a sweat test, and it's promoted to be assisted at a CF center. And this law is important because everyone who has CF must get the CFTR modulators if they are allowed to. If the mutations are correct, they must be allowed. And there is two generic bioequivalents that in Argentina that is they are selling. One is Trilexa and the other is Trixacar. It's their work as well as Trikafta. So everyone who is diagnosed and it's have the mutations who is allowed to get the medication by law, they must tell it. We are a mix in Argentina from Europe. There are a lot of Italian and Spanish people. So our patients are most eligible for CFTR modulators. Just only about, I think there have only 8 patients that they are not eligible. So most of them they are taking Trilexa or Trixacar. I think the challenges in assisting patients in Argentina are we have fragmented healthcare coverage. There are access disparities between different regions in Argentina, the north and the south, and the middle of the country is quite different. We have some centers there, but not in the north and not in the south. So patients have to travel a lot to get to a good assist. Also, the coordinations between child centers or pediatric patients and adult centers, they are not so fluently or not so common. And that's our challenges that we have to arrange. And also, I think the geographic barriers, the travel burden for patients from remote areas are the limited centers that are in Argentina. There are also resources limitations. Perhaps in some centers you have access to specialized diagnostic tools like sweat test or the availability of multidisciplinary teams or laboratory and imaging capabilities also. And I think that the late diagnosis, it's a worry in Argentina. We have one patient that is our oldest patient that is 73, and she was diagnosed at 60s, as she's her 60s, because of she was assisted by his asthma crisis. She was absent to 3 appointments to the physician. And when the physician asked her why she was absent, she said that it was because of the pancreatitis. So the clue was there, and she was diagnosed at 60s. And nowadays she's 73. Every year from, I think we started in the 2022, we are doing a preceptorship to try to most people or physicians from Latin America starting doing centers there. So we assist like Europe or US with nutritionologists, nurses, psychology, pharmacists, internal medicine, pulmonology, gastroenterology. I don't want to forget now when hepatology, physiotherapy. And when the patients came to the appointment, they start rotating every specialist in one morning. Everyone is getting to the all specialists. So we are trying to get that in Latin America. I know that in Uruguay and Chile there are some centers, but they are trying to get it in Paraguay, Bolivia, and also Peru. They are trying or starting to getting some centers there. In every conference, we show our results of some resources or research that we made. And the last one was a comparison between CFTR modulators that are in Argentina and the original one. So we get 100 patients, compare a comparison between them, and it was as good as the others. And we have some resources about inhaled antibiotics. We made a protocol that it won a bursary of KESI last year in the European Cystic Fibrosis Conference. It was about eradication of Burkholderia cepacia. We tried to eradicate it. We started with every sputum culture. Every sputum culture was given to microbiologist and virology. So we started looking for the gene RIC-A that is from Burkholderia. And in ones who get it, we started eradication plan that it was about ceftazidime and minocycline. And we eradicated by PCR in most of the patients. So we get it, fortunately, with a fast success. So we try to eradicate it. Just 2 patients were not eradicated, and there were when we tried to look at the microbiology that they were in a childhood, there were some success of cepacia in that moment. So the only 2 patients were in childhood. They have some cepacia isolations there. The hope is to be cured as in US and Europe and all around the world. And I think we have lots of developments in gene therapies and next generation treatments are going to be really success. We are fortunately um, living a part of the disease that we have lots of changes and incredible transformations in our patients, our patients' lives also from young adults who perhaps thought that they'd never be graduate or at university, now proving their careers, couples starting families, they never perhaps thought that it was possible. And I think the future is bright, and we are committed to ensuring every patient has access to life-changing treatments, and they deserve it.